half of women and a quarter of men over 50 fracture due to a fall from osteoporosis. And these are older statistics. I haven't found newer ones, but you get the picture that it's quite prevalent. The other statistic I found was that it's more prevalent than heart attack, coronary artery disease, and diabetes.
Hey there, and welcome back to another episode of the Reshape Your Health podcast. I'm your host, Dr. Morgan Nolte, and today we have a special guest. She's actually been on the podcast before, way back in the early days of the podcast. Her name is Betty, and the first episode was about how she reversed her prediabetes with our Zibly program. She's been involved with Zibly for years and just become, quite the member, Betty, I have to tell you. And I just really appreciated your involvement in the community and office hours, and you've really kind of helped inspire a lot of our members over the last couple of years. So thank you for that, first of all. Secondly, she has osteoporosis. She's had low bone mass, kind of gone back and forth between various diagnoses. And she's a physical therapist too, and with multiple certifications in bone health. So she has a really unique perspective and experience and education on bone health, both from a provider and a patient standpoint. So if you have low bone mass or osteoporosis, or you know someone that does, I really hope that you glean some wisdom and insight from this presentation that Betty put together, and just from her own life experience. So Betty, thank you so much. I know you put a ton of work into this presentation. This is our second time trying to record this, by the way, because the first platform was not agreeing with us. So we're doing it on Zoom, and I know it's going to be great. So thank you, Betty.
Thank you.
Yes. All right. Go ahead. Just dive in. I'll let you give your presentation that I know you put a lot of time into.
Hello, everyone. Imagine that you get a phone call from the medical assistant of a gynecologist that you just saw one time, and they tell you, your bone scan came back, you have osteoporosis, the doctor wants you to take this pill. That was it. That was all she told me. And I was scared. I included this picture because that was the way I saw myself at that time. That was 2015. I was 58 years old. I felt active. I loved hiking. I loved going to the mountains. And my vision of osteoporosis was being very frail, being very limited in what I could do, pain, and all of that. So I was scared. So I filled the prescription, believing all the commercials I saw. And I came to the point where I was sitting on the couch, holding the pill, glass of water at my side, and getting ready to take it in. And I said to myself, no, you need to learn more. And at that point, there wasn't a whole lot on the web. Now there's a whole lot more than there was at that time. But fortunately, being a physical therapist, there were continuing education opportunities, and I learned a lot along the way. So what went wrong with what happened with me? First of all, there was no explanation about the medication, no warnings, no anything about what I should expect. No further testing was done. Generally, there's lab work that's done to help determine secondary causes of bone loss, to evaluate your nutritional profile and so forth. And that hadn't happened. This was one test, and I don't believe she had my prior tests, but still, this just happened. This was actually my third bone scan, which is unusual at that age. But in any case, this was really based on that, because the prior ones didn't have any indication of bone loss. And there were no recommendations regarding diet, regarding exercise, and so forth. Below this screen are some links to a summation of some lab work that might be done if you're considering medications, if you get a diagnosis. One's a video and one's a really in-depth article, but it has a nice little summary of tests that might be done. One of the things that
Sorry, Betty, just for our listeners, I forgot to tell them we are going to give them the slides that have the clickable links because Betty put a ton of resources in here for you. And so you can download the slides. We'll just put them in the show notes. All right. Sorry for interrupting, Betty.
No problem. So where was I? First I want to say that as far as meds go, none of what I'm saying is in opposition to meds, but I think you need to understand why you're taking them. Be confident that they're necessary. And it's a personal decision between yourself and your healthcare providers. But in the manner that it was prescribed to me, it was just, I think, insufficient data to come to that decision, and possibly, in my opinion, detrimental. The other thing that I wanted to mention was exercise wasn't mentioned, and exercise is my opinion, and and lots of experts agree that exercise should be a first-line approach, not just a secondary adjunct. Would be nice to do. It should be a first-line approach to treating it, and it can avoid or put off the need for medications. So I found another doctor and moved on. I had several DEXA scans over the years, and on my DEXA scans, that first one was in osteoporosis. 6 years later, I was in the osteopenic range. It's not hugely significant because you can fracture in both ranges, but changes did occur over that period of time. And pretty much my DEXA scans have been stable. When by that I mean there have been some increases, there have been some drops, but it's been basically stable. In spite of the fact that I decided not to take medication. Lots of people have different opinions about DEXA scans. For me, it changed my life, really, because getting that diagnosis got me really serious about learning about exercise. Often you don't have DEXA scans until you're 65 years old. If I had my first DEXA at 65, I suspect that my bones would be in a lot worse shape than they are now. The other factor to consider is when you're just going into menopause or early menopause, hormone replacement therapy. If some people even say after early menopause, but hormone replacement therapy was never an option that was presented to me. It's definitely most effective right around menopause in preventing the bone loss, because there's a large loss of bone that occurs right after menopause. And that might be something that's appropriate depending on your individual situation. As I learned more about osteoporosis, I found just how prevalent it is, and I was unaware of that. Half of women and a quarter of men over 50 fracture due to a fall from osteoporosis. And these are older statistics. I haven't found newer ones, but you get the picture that it's quite prevalent. The other statistic I found was that it's more prevalent than heart attack, coronary artery disease, and diabetes. And as I was learning more and more about it, it became important to me to share the information. So here we are. And on we go. So the highlights of our talk. My objectives are going to be for you to learn some about osteoporosis and find some resources to learn more. And if you need to gain the confidence about learning to do more and move safely. Every movement and exercise isn't right for everyone. understand where you are and do something. I'm going to talk about what osteoporosis is, common sites of fragility fractures, some diagnostic tools that are used, bone strength, density, and quality, objectives of treatment of osteoporosis, movements to limit, alignment, balance and fall prevention, and strengthening bone with exercise. On this first slide, the image shows you what osteoporosis looks like. If you look on the left, that is a drawing of a femur, and the rounded section is the head of the femur, where it joins with the hip joint, the pelvis, the socket of the pelvis. And if you look down the shaft of the bone, the dark area labeled cortical bone is a section that it's more prevalent in the long bones. It's denser bone. Notice as you move to the top of the image, there's less of that dense bone. And there's more of the crosshatch bone, which is called trabecular bone or spongy bone or cancellous bone. And those terms are used interchangeably. Osteoporosis fractures occur most frequently in areas that have less cortical bone and more trabecular bone. The little section that's marked by dotted blue line, that's the femoral neck. And I pointed that out because it's a very small section of bone, but it is big on the DEXA scan, and we'll talk about that later. On the right is an image of normal bone, and you can see the thick connecting tissue around the pockets, which in those pockets is where bone marrow lives. And below is an osteoporotic bone. This one, very osteoporotic. But the thing to keep an eye on is where those arrows are. And those are areas of microtrauma or microfracture. And the bone does not have to be that far along in osteoporosis for that to occur. So the sites where fractures most commonly occur include the spine. That's the most common. And if you'll notice in this picture where you can see the nubs on the left, that's the part of your spine that you can feel if you touch your back. And then the front is the vertebral body. And you can't palpate that, you can't see that, but that's the area that that's trabecular bone rich and is affected by osteoporosis. In that picture, it's bent just to show that when you bend, pressure on the vertebrae, when you bend forward, pressure on the vertebrae is more. And that's where the compression fractures occur. And this one shows a couple of web fractures kind of in the middle. I don't know if you can see my cursor, but right around there. And the other areas are the hip and the wrist. Other areas affected commonly are the ribs and the pelvis, but really the fractures can occur anywhere. Next, I'm going to talk about DEXA scans, and DEXA scans are called the gold standard for diagnosis, and to some extent, they are the standard for diagnosis because often the diagnosis is made based on the T-score, and the T-scores come off of the DEXA scan. So there you go. The list of the score cutoffs between normal osteopenic bone or low bone density and osteoporosis are listed. Sometimes osteoporosis is diagnosed without a DEXA based on a fragility fracture, which is a fall from standing to the ground, or any fracture that that occurs where normal bone normally wouldn't fracture. So other ways osteoporosis may be suspected is if there's a loss of height more than 2 inches, hyperkyphosis, which is hyperbending of the thoracic spine, the upper spine, back pain, and a protruding abdomen, because when you have that curved posture, your organs have no place to go but forward. DEXAs give you a lot of information and a lot more information than T-scores. And by the way, the T-score is a statistical determinant that occurs as a comparison of your bone to quote normal bone, which is approximately to a normal 30-year-old of your same sex. But DEXA scans are not infallible like any test. There are errors that occur. Errors occur if the machine you're tested on isn't calibrated properly. If the regions of interest, the regions of interest are shown in red in that picture of a hip in the slide to the right of the DEXA scan. And errors can occur with the positioning, and that can give you faulty readings as well. And there are other things, but those are some common ones. DEXA scans should be done on the same machine, preferably by the same technician. What does that tell you? It tells me it's not all that exact. So if you're talking about small differences as a determinant for medicine or not, you might want to look more at trends than just taking that one score as, okay, now it's time. But in any case, the femoral neck is the area where most of the errors occur. So in my case, with that first diagnosis, when I went to my new doctor, the doctor said they didn't get the regions of interest correct. I went back for my next DEXA, which was in 2017, and the technician corrected it and then came up with the new DEXA. And just by the correction, there was an improvement from minus 2.56 to minus 2.5. Not huge, but a difference. And the difference really could have gone either way. But the point is that there can be changes. I will tell you over time, that same hip has improved as much as minus 2.2. Last DEXA was minus 2.3. So changes happen. And then there's the Echo Light. Echo Light is a new diagnostic tool just coming onto the US market. I'm not sure how insurance covers it. It's not offered in a lot of places. Some people say it's better than the DEXA. It uses ultrasound rather than X-rays. So although the DEXA is low X-ray exposure, the Echo Light is none. Some people love the accuracy of it and think it's better. Some people think it's not as good. I've heard both. So just something to watch. The DEXA scan, and I should mention, when you get a DEXA scan, they look at your hip and they look at your spine, and sometimes they look at your wrist. And when they look at your spine, they look at the lumbar spine because the ribs attach to the thoracic spine, where most of the fractures tend to occur. But pretty much what DEXA tells you is how much bone is present. But that's not the only component that determines a fracture. The other component, and I've seen, they're pretty close in how they affect bone. If you have really, really, really thin bones, like if you're looking at -4s, bone quality is going to be less effective. But if you're looking at -2s, maybe even -3s, the bone quality or qualities is going to make a huge difference in the strength of your bones. The two of them together determine strength. Bone quality or qualities include the geometry, the size, and the thickness of the cortex. The microarchitecture, the way the trabeculae are organized, and the micro damage accumulation. So that little damage that I showed you, more of that means your bones are going to be more fragile. Properties of the tissues that can determine how your bones can absorb shock and disperse forces. So if they're super hard, they're going to break more easily. If there's a little bit of give, then they might take an impact better. And also the rate of bone turnover makes a difference. Exercise may improve quality without improving the density or improving the density significantly. Two times I've seen that cited was one on Morgan's interview with Dr. Laura Bialik, and she mentioned that in her study, while there weren't big changes in density, there were changes in the thickness of the femoral neck. Also, Dr. Belinda Beck, who did another very famous study called Liftmore, which I will mention again later, she found that while her participants lifting heavy showed significant improvement in the spine, but in their hip, there was not so much improvement, although they did improve less than 1%. But she questioned how they could be doing all that, but found on later examination through laboratory instrumentation and software that the cortex of the femoral neck had actually gotten thicker, particularly in the regions that tend to fracture. And I heard that in an interview she later did. So there is one test that's available now that I'm aware of that's not in a lot of places, and I have provided a link to where you can find it. If you use that link, know that everything on that link, they're not going to know what the trabecular bone score is, but you are likely to find someplace. I did that and was able to find some places that actually have this software. It's software that attaches to the DEXA scanner and gives you more information about the quality of the bone, the way the trabeculae are arranged. Just to give you an idea how that impacts someone, if you look at the picture on the top, both these images have the same T-score. In this case, minus 2.2. The top, and this is a adaptation you can see on the slide. This comes from the Medimaps website. In any case, the picture on the top is really dense and like evenly dispersed. It's labeled as normal, even though it's in the low bone density range. The bottom one is degraded. Those dark areas are like holes in the bone. It's a little bit clearer on the graphs. And you can see just by the way the bone is arranged, the one on the top looks like it can withstand forces a whole lot better than the one on the bottom and be less likely to fracture. And next, I will talk about the FRAX. The FRAX is nation related. It's an algorithm that was developed. There are several, but this one is the one that I know that's most commonly used. You can find it online, and the one that this is from, the US one, I have a link for it. And they ask you several questions, so it takes into more factors than just your DEXA. And it's the newer versions, I think, are also incorporating TBS scores if you have them. But it takes all this information into account and gives you a prediction of if you might have a major osteoporotic fracture or a hip fracture within 10 years. And the thing that I recommend that you do with this one is scroll down below the questionnaire and read what their criteria for each item is. Some of these are pretty straightforward. Some of them are not. And one thing that happened to me, also sometimes your imaging center will calculate the FRAX along with your report. My imaging center did, and just asked me some questions. I didn't even think about what they were for. And they asked if you ever had a previous fracture. If you read the definition, the previous fracture they're talking about fragility fractures. They're not talking about any fracture. In my case, I had a big bench fall on my big toe when I was in my 40s. So I had a fractured toe. Generally, aside from that, that was not a fragility fracture. Fingers, toes, and facial bones are not usually considered fragility fractures. But in any case, my gynecologist got the report. This was after my best DEXA at the time, the first one where that right hip wasn't in the osteoporotic range. And the risk was way higher than it had been, and it was high. And she was thinking, maybe we need to start thinking about medicine. And then I kind of sorted it out, looked it through, contacted her, showed her about how the FRAX works. She contacted the imaging center. And although my imaging center would not make a change, we both agreed that the risk was not accurate on that report. So from here on in, I say I don't have a previous fracture, and hopefully I will continue not to have a previous fracture. So moving on from here, what are the objectives of our treatment? Our goals are to prevent those fractures and subsequent fractures, to reduce or minimize deformity, and to minimize pain. I'm highlighting that because a lot of people, especially when I hear them talking about medicines, they're talking about improving T-scores. T-score isn't the criteria, it's part of the picture. Really what you want to do is improve your bone health and not be injured. So first off, what you need to know is the movements that you want to limit. And those are highlight the ones in the center, curving your spine. And I already explained that on the other picture. Again, here on the left of the picture of the spine, those vertebrae show 2 wedge fractures. And that could be the result of compression on the spine. When you do these movements, which aside from the curling, which can be to tie a shoe, which can be for exercise, which can be when you're making the bed, whatever. The other movements that you want to avoid are side bending and trunk rotation. And the reason is because those can also put pressure on those vertebral bodies. Putting pressure on the vertebral bodies might increase that microtrauma, and that microtrauma can eventually lead to a compression fracture, or the movements can cause a compression fracture. So the text of this comes straight out of the Bone Fit Manual, which is, of course, one of the courses that I've taken. And they say the movements to limit are these 3, and you want them not, if you're doing them, you don't want them to be repeated or sustained. You don't want them to be with weight. You don't want them to be to the end range. That means as far as you can go. You don't want them to be rapid and forceful. And the more of these you include, the bigger the risk. So you don't want to do them in combination, and you don't want to do the movements in combination either. Again, even if you do them and you don't have an injury, they can be increasing microtrauma, which you don't know. So other things to be careful about, if you're lifting a heavy object like a suitcase from an overhead bin, you want to, if you're going to be doing it, you want to be able to lower it with control. If you can't, you can see where that would pull you into that curled position and put stress on your spine with weight, probably rapidly and forcefully. You want to reduce the cumulative effects of gravity. All of us get called into gravity. You want to correct yourself. You don't want to slouch. You want to set up your workstations so that you can show good alignment. I'll also mention standing and lying are less compression on the vertebrae than sitting. On the hip, when you're doing rotation, you don't want it to be forced, and you want to avoid the end range. Surgeons may tell you not to do certain movements if you've had hip surgery, but find out for how long you shouldn't do it. And finally, my little illustration, this is my visualization of what happens to the vertebrae. If you look at that Jenga game, you set it up, it's all nice and stable. You pull out one little block and it's still pretty stable, another, it's still pretty stable. And eventually the whole thing falls apart. And that's what I envision happens with vertebrae too. So you want to really try and avoid that microtrauma when you're able to, and do the movements carefully. So next I'm going to speak about alignment, because alignment is the key. It's the foundation. In the clinic, lots of people told me I've always had bad posture, and that was the end of that. I heard that so many times. It can be better. And it's not just an aesthetic thing, although it is an aesthetic thing, but it'll affect the compression on your vertebrae. It'll affect the space your organs have, and they will operate better if they have all the space they're intended to have. It can harm you, set you off balance. It can affect your breathing, and it can affect your shoulder mobility and lots of other things. So alignment is important. In the illustration on the left, the guy's standing with great alignment, and his low back, his sacral spine, his thoracic spine, and the back of his head are against the wall, and that's what you're after. If your head comes forward, you want to work on improving that. Another test you can do for your posture is if you place your fingers between the lowest rib that you can feel and above your pelvic bone or your hip bone, as most people know it, but that is not your hip joint. If you can fit two fingers or less between the bottom rib and your pelvis, you may have some compression fractures, and you definitely want to try and improve that alignment. Just if you look at the guy on the left, that is not only a test position, but it's also an exercise that my husband really came to like because he had difficulty getting his head all the way back, and he will still sometimes walk up against a wall or a post and just try and bring his head back to it with eyes looking straight ahead. And if you have difficulty doing that, you can build the area up, possibly with folded towels or a pillow, but try and keep that head aligned and tighten your abdominal muscles and just try and bring your head back in good alignment. Another exercise I have given you a link to, I'm going to say it real quick. It's an exercise by Sarah Meeks. Sarah Meeks, I think of as the mother of osteoporosis physical therapy. I have a certification from her, and I've taken several of her courses. And in this exercise, and all of her exercises are quite detailed in her explanations, so it's really good to look at what she says. But this one, get your weight evenly but on your feet, stand as straight as you can, or you can do it sitting, either way, evenly. And think about pressing your feet into the ground and envision a feather at the top of your head, and you're trying to lift up to get the feather off of your head. And that's just a nice stretch to do whenever. And you, as I said, you can do that in sitting or standing. If you do it when you're measured, you're probably going to be taller. The next thing I'm going to talk about is Sarah Meeks' realignment routine. And I'm not going to, again, go into detail. In the center, I gave you a real quick description of these two exercises. And on the next slide, I'll show the rest of them, but not to tell you about them. I have a link to her instructions as well as video of her instructing it. So you can enjoy those. But these two positions, I find them to be heaven. Last night I went to sleep in that position on the left. It's a really nice relaxation position, and it allows your spine to open up and your intervertebral discs to hydrate, and it helps improve alignment. And there are adaptations in there. The one on the right incorporates breathing in it. So if you put a weight on your abdomen, and so the weight might be like a cell phone or a book, around 2 pounds, and around the area of the navel or just below, and think about breathing in and breathing out. Those are really nice and really relaxing and can help relieve pain. So here's the rest of the routine. I will say, doing those first two, I've seen people improve their shoulder range of motion. And now we have an image, a Sarah Meeks image of Sarah Meeks. And if you're sitting for a prolonged period of time, using a perch posture is preferable to sitting with your knees higher than your hips or even at hip level. In this position, it helps you with your alignment. And as I mentioned, sitting puts more compression on the spine, so that helps with that some. Although I don't know if there's studies on compression with perch sitting. Hinging, once you get that nice sitting alignment, then you want to learn to hinge. And here they're demonstrated in sitting, but you do this with all your mobility. So here she's placing her hands in her hip crease between the top of her thighs and her abdomen. If you lean forward and your fingers get pinched, then you are doing it correctly. If your abdomen moves away from your hand, then you're rounding your back and you need to think about learning to correct. The other alternative is using a stick, again, placed over the sacral spine, thoracic spine, and the back of your head, and working on leaning forward as one unit. And again, if you're not at a point where you can bring your head back that far, you can put something on the stick to make it a little thicker there. So after you learn to hinge, you want to incorporate it in your mobility. And lots of examples on the web of good, safe body mechanics. These came from a couple of different sources. I think that one came from Sarah Meeks, one came from the Bone Health and Osteoporosis website, and a manual that I've given you a link to. When you're sitting in a chair, particularly if you're reading, you want to hold it at a level where you can look at it without curling. When you're putting on shoes, you use a platform or cross your leg, but you want to avoid that bent over position. Coughing and sneezing can cause you to round your spine, and in some cases have caused vertebral fractures. So if you place a hand on your back or stabilize on your thigh when you're coughing or sneezing, that will help you reduce the curving of the spine. When you're bending, you can either use a squat. There's a beautiful squat there on the bottom left, or you can use a golfer's reach, as is shown on the top right, or with the woman reaching into the refrigerator. Getting onto the ground, if you can get in and out of half kneeling. Half kneeling is a good position rather than bending over with a rounded back. And when you're doing yard work, you don't have to reach really far away to rake. You just kind of have to go with whatever distance you can while you're maintaining your alignment. And the mid picture in the center. As I mentioned, or maybe I didn't mention, some of those movements just have to happen in life. And that's why they say limit them and never do them, because sometimes you just have to do them. And in this picture where it says this way, not that way, she is twisting, as you need to do for driving, but she's stabilizing on the steering wheel and she's keeping her back nice and aligned, as opposed to the not this way method. So now that I've spoken about alignment, I'm going to talk about balance. Balance, you may have good balance, you may think your balance is terrible, but it can improve and you should practice it, because it's another one of those things. As you get older, if you don't keep asking for it to stay with you, it gets worse. Exercises should be easy enough for you to do, but hard enough for you to be a challenge. If they're so hard you can't do anything, they're not going to do you any good. And if they're not challenging, they're not going to do you any good. So roughly, I'm using that 70% success example. Since balance puts you at risk for falling, have support surfaces like counters, chairs, walls, things that are stable that you can hold on to, so that if you do get thrown off balance, you can catch yourself. If you need a support to do an exercise, take as little support as you need. Take as much support as you need, but as little as possible. Everyone is at their own level. So begin where you can be successful and where you can be somewhat challenged. To make an exercise easier, you use a wider base of support. To make it more difficult, you're going to make your base of support narrower. So you might start standing on 2 feet. You might put 1 foot ahead of the other with a little space between them. Put your feet, then have heel to toe, one foot, kind of like in a sobriety test, walking a tightrope. And finally, you might try standing on 1 foot. That's how you narrow the base of support. Further difficulty, try closing your eyes. Try turning your head. Try moving while you're doing, if you're doing a static exercise, try moving your arms or your legs with the exercise. And try using a softer surface that you're standing on. Could be carpet, could be foam, could be a Bosu ball. Anyway, those are the various levels to make the same exercise more difficult. The picture on the left from Sarah Meeks' course book, both, the individual is leaning from side to side, and that's an exercise for limits of stability, which I'm going to talk a little bit about in a moment. So this is a nice breakdown that I got from Dr. Laura Giangregorio, and it was in a YouTube video, and she graciously gave me the slide. And it breaks down the different components of balance. In reality, some of these are going to be done in combination some of the time, but when you're doing an exercise program, you want to think about the categories and think about the different kind of challenges you can have. So first is anticipatory control. Picture of a tree pose. You kind of first shift your weight to one side before you lift your foot and prepare yourself. You know what you're going to do. You prepare yourself for the diminished base of support. Another kind of anticipatory control would be if you're out walking in the woods where there are lots of roots and rocks around, planning your course so that you don't trip. Then there's dynamic control. That's moving your center of gravity through space, as you do when you sit to stand, and you want to be able to get between ideally sitting and standing with good control and not plopping onto your chair, and if possible without using your hands, but that for some people you have to work up to that. But it's basically maintaining control as your center of gravity moves. So that's even walking, or it could be heel to toe walking, a tightrope type walking. It could be walking stairs. It could be moving up and down from tiptoe or standing on your heels, or walking on tiptoe or walking on your heels. Some examples. In the picture below, that was an exercise I often did to work with people on gait, because that was the population I worked with. And she, who was me, was taking a step and touching the ground with her heel. And then it's a shift forward onto the front foot, and then a shift back, and you can even lift the toe up on the back leg. And just doing that shift while maintaining your alignment. There's sometimes a tendency to bend forward as you shift onto the leg that you're standing onto. So that's another version of dynamic control. Next is functional stability limits, as was in that first picture, where the individual was leaning different directions. And you can do that same exercise standing next to the wall and just trying to reach so that it's just beyond your fingertips, but just have something that you can catch yourself on. You can do that forward. You can do it backwards, but don't get very far from the wall. There's not a lot of range in your ankles to shift your weight backward, but if you're an inch or two away from the wall, you can still work on shifting your weight backwards. Any other ones? We'll just go with that for now. And then the last area is reactive balance. And just a second, I'm going to move this. Okay. with reactive balance is pretty much harder to do on your own, really, because reactive balance is how you react when you're not going to fall. And in the clinic, there are ways you can safeguard against that. It's a lot harder when you're at home, but some things, so you want to basically surprise yourself when you're doing whatever movement you're doing. Playing a game of catch with someone, if your balance is good enough on 2 feet, that's one way to do it because you don't know exactly where the ball is going to go. Another way to do it, if that's easy for you, is standing on 1 foot. And for me, that's a lot harder. I sometimes do that. Let's see. Then there's the Clock Yourself app, which is an app you can buy. It's pretty inexpensive. You stand in the center you envision yourself standing in the center of a big clock, and it gives you different directions to step. So you're reacting quickly and you don't know which way. Well, as quickly as you choose to, because you can adjust the speed, but you don't know where it's going to tell you to go. Another thing that I do that I started doing is I sometimes will take a large step in different directions, in random directions, and then try and hold my standing position on 1 foot for several seconds. And then I've progressed to doing that with a little hop. So it's really hard to prepare if you're actually hopping onto the foot. So that's another exercise that I do, but again, it's a progression. Tai Chi has been found to prevent falls and to improve balance, and for the most part, I think incorporates all of what's shown here. So moving on to fall prevention, aside from improving your balance, is avoid obstacles, have your home set up so that it's safe, have adequate lighting, particularly if you're going to be getting up and going to the bathroom during the night. And you especially don't want obstacles if you're going to be getting up and going to the bathroom during the night. You want to be aware of your surroundings if you're in a hotel, a new place, and or hiking a trail and the ground is unfamiliar. You want appropriate footwear. I can't tell you how many people I see out hiking in flip-flops, particularly if you have bone issues, and even if you don't, flip-flops are not for hiking wilderness trails. Also, increasing your strength, because if you do start to fall, you want to have the strength to break that fall. And then I will talk about just mentioning power and speed, and I have that with a question mark only because I looked for data to validate what I think. I found a little, but not a whole lot. So I'm just saying I believe it can help improve your ability to make a fall less impactful or prevent it altogether. Because when you're about to fall, you have to react quickly. But aside from having the reflexes to react quickly, you also have to have the strength to trigger quickly. And as you age, your fast twitch muscle fibers, which allow you to react quickly, also diminish. So one exercise that I do and have done for a long time is I do 30-second sit to stands. So I see how many times I can do that in a 30-second period. Then I've since added weight to it and then more weight to it. And that's one way of training power and speed. On the next slide is the description from the BoneFit manual. That is the entire section on power and speed in the BoneFit manual. So, but it has good information in it, so I just copied it and put it in there, and you can read that at your leisure. So now that I've covered all that, let's talk about making your bones stronger. Whatever exercise you choose, it should be appropriate for the individual. Be mindful of your joints and your weakest links, which is often the joints. You're running your own race. It doesn't matter what other people are doing, how heavy they're lifting. You do you. Honor your capabilities. We're different. Find things you enjoy doing. That makes it a lot easier to do. Take rest between exercises, both, Wes recommended both with strengthening exercises, with resistive exercises, and with aerobic exercises. Rest periods allow you to come back stronger, so you can have more of an impact on your bones. Surprise the bones. So that's a common phrase used. If you change your direction, your speed, your surface, even your focus, the forces of the muscles on the bones will be different. And it's thought with change, you're going to have more opportunities to build bone. Good body mechanics and alignment is critical. So think about your mechanics, your optimal alignment, and your core stability. Don't add stress until you have good form, and don't add more stress that will take away from that good form. The benefits of resistive exercise are site-specific on bone. So whatever areas you're working, that's the area that's likely to affect the bone. And always warm up and cool down. So the types of exercise that strengthen bone, again, find your level of exercises. Weight-bearing exercises, including aerobics and impact. Resistive exercises. Speed and power, again with a question mark, because I know it's out there, but I couldn't find the data to say, or much data. I saw some suggestion that it does improve bone, but I haven't really found very much enough to say, and has not been really included in the courses that I've taken, except for that brief mention in Bone Fit. And then I'm adding blood flow resistance or restriction because, and I'm using both terms because I've heard both terms used. I took an online continuing ed course that was done by Ed LaCara, who is a chiropractor. And I also spoke to Brett Burton, who Morgan did a prior talk to, about its use in osteoporosis. It was originally in that continuing ed course that I saw that it mentioned, and Brett had confirmed that there's some evidence to show that it can be effective, particularly with people who are unable to do hard exercises. Not to say that it doesn't work if you can exercise aggressively, but there isn't really a lot of good lab work on to show that it does. So that's the reason for the question mark, but I think it's something to watch in the bone health field. Below that, I have a whole list of warnings to be cognizant of, to know about if you're going to start doing an aggressive program. Consult with your health professionals. First exercise I'm going to talk about, aerobic weight-bearing walking. That's the lowest lying fruit. At times, that's what I've been told. Just walk for bones. Well, it's not that simple, but and I've heard different things about if it's effective, if it's not effective. The information here comes from a blog on Melio Guide that Margaret Martin did. She's got lots of information out there. It's a very comprehensive blog. And based on the research that she looked at, she said that minimum speeds of 2.5 miles per hour can preserve bone, and 3.1 to 3.7 can build bone, primarily at the hips and the femoral neck. So she was less convinced about improvements of the spine, although again, the information is somewhat shaky. Breaking up the walks in time may allow you to be more aggressive, because a lot of it's the impact that's impacting the effect on your bones. So if you're walking faster, there's more impact with the ground. And if you're not fatigued, you can have more impact. But you have to build up to increasing your speed. When you walk faster, you also increase your fall risk. So you have to weigh that. So one strategy for increasing speed is to time yourself going a short distance, say from one corner to the next, and then gradually try and increase that speed, and then do that several times. If you have difficulty getting to 3.1, 3.7, that's pretty fast. So even 2.5 can be kind of fast. So do what you can, do it safely, but think about increasing the speed. And while you're thinking about that, also think about different aspects of your walking. Think about standing tall. Think about your arm swing and your strong and your stride length and your breath. And changing your focus will change how you do it and how you use your muscles and how that impacts your bone. Where you walk, walking on varied terrain is going to be more stresses, more surprise for your bones, and different stresses on your bones. On hills, on steps, avoid bending forward. There's a tendency for that, so keep that in your mind. Remember your alignment, especially on hills, and on knees, you may want to zigzag. And one thing I think I forgot to mention earlier when I was talking about alignment is, with all the stuff we do with the exercises, with the strengthening, remembering to improve your alignment several times a day is huge. Nobody is perfect all the time. Most people aren't perfect all the time. I'm certainly not. And you can self-correct. Keep it in mind that self-correcting is a good thing, and gravity is a force, and you need to challenge it every now and then and say, no, no, you're not going to make me slouch. So moving on, I'm going to talk about Nordic poles. That's me, and walking with my Nordic poles. I really like the brand that I have. I don't sell them. They don't know me. The ones I have are Exostriders. There are lots of ones out there. What I like about these is, I tried to show a picture to show you, but there's a little kind of support at the side of your hand. So when you press and push, you really feel like you're getting weight bearing into your arm. And they have these little booty things at the tips that grip the ground nicely if you're on concrete or more solid ground. Using Nordic poles can help you take stress off of painful joints. It allows walking to become a full body activities and increase the cardiac workout. And it can also improve your safety and control on hills. So additional weight bearing, power impact exercises, find what works for you. Continuing theme, planks, doing wall slides. That's when you stand up against a wall with those 3 areas of contact and try and get into a sitting position and maintain the sitting position while you're standing against the wall. Walking up and down stairs. And again, you can do that and incorporate speed with that. You can change the way you impact the step with that too. You can change it up, but have rails available to you, especially if you're working on speed. I have steps in my home. I use them for exercise, and I do vary speed. And my steps have a little lip, and it's more than once that I've caught a toe on the lip of the step. And I have 2 handrails by my stairs. I don't use them for weight bearing or to help me up, but I use them so I have that support there if I need it. Next, moving on to impact. Impact, particularly with severe osteoporosis, may or may not be recommended, and there are varying levels of impact. Also with other joint issues. So know yourself, consult with your health professionals. Heel drops, which is basically getting up on your heels and coming up onto your toes and coming down onto your heels. Melio Guide has a nice description of that. And so there's a video that I've linked you to. One thing I'll say about heel drops is, if you have a propensity to plantar fasciitis, might not be the best exercise. The other thing is stomping, and that's basically stomping with your full foot. And again, I have linked you to Amelia guide demonstration of that. Jumping is something that I have included in my exercise routine for a very long time. It's something that I've built up to, and is recommended for some, not for others. You just need to find out if it's suitable for you, but you do get good impact. I am told that an impact of twice your body weight will build your bones. I don't know. I don't know how you know if you do twice your body weight. I just do the best I can. I have progressed to doing to jumping rope, 2 sets of 100. Some people say, I've seen it said that more than 10 jumps or more than 50 jumps is not going to be effective. I still do my 100. Dr. Lainey Simpson, who has a book about bone health, also has a video about she does 300 groups of 10. When I do my jumps, I try to vary my speed, vary the height of my jumps, vary the direction of my jumps. So that's just to give you an idea, but don't just go straight into jumping rope if you don't jump at all. And if you have arthritic issues, or if you've got really fragile bone or other medical conditions, verify that you can do it first. Hopping is another exercise that has been documented as helping with improving bone. And from the study I'm aware of, they did 50 jumps in groups of 10 with 15-minute rests between them, and progressing to hopping in different directions. Again, it's something that you work up to. You might work up to it using the stomping or the heel drops before you actually do the hopping. When I do it, I intersperse hopping between my other exercises, and that's how I get my groups of 10 in. Running is similar to walking. So same variations as we discussed with walking. Generally, I should say that sprinters have better bones than marathon runners. So speed, again, is going to have a better effect on your bones, but you can't fall when you do it. So you've got to do what you're able to do safely. All right, so we'll move on from here and talk about resistance exercises. To build bone, you have to train at higher loads and fewer repetitions and use more weight than you use in your normal activity. You can use weights, you can use your body, you can use resistance bands. All can be effective. Moderate intensity exercises, 8 to 12 reps, up to 15. High intensity exercise for the purpose of building bone. I expect that some people do fewer. 5 to 8 reps is what I've heard. With moderate intensity, which is pretty much what I have done and what I've seen documented, you can maintain your bone. For me, that means I've been doing this since 2015. My DEXAs have stayed quite stable. So I consider that a win because I'm older now, and you generally lose bone with age. High intensity exercise is more effective in building bone, but you have to build up to being able to do that safely. The Liftmore study is big, recent, well, it's 2018. I guess it wasn't super recent, but it gets a lot of buzz because it's the first one that really started using high resistance exercises. I've just given a quick outline of what the study is about on the right if you want more information about it. But I will say that I heard Dr. Belinda Beck talking about it, and she was the one who designed the study, I believe, or at least one of the people who designed it. And she said that she wouldn't tell what exercises they did. They are in the study. They are all over the web. Why wouldn't she say what they were? She doesn't like to say them because She didn't want people to just go out and do them at the level where they fatigue at 5 to 8 reps. Let me clarify that when I say 8 to 12 or 5 to 8, that's the level where you fatigue, where your form will break, or you feel like maybe you have 1 or 2 left in you, but it's really hard at that point. You're feeling the strain. She did not want to tell people what the exercises were because she didn't want to be encouraging them going out and doing it. So that tells you about building up for it. Also, if you're using that heavy weight, you might need a spotter when you're learning to do it. Anything else I need to tell you about that? So you build up to that level with some knowledgeable help, as I said there. Stop before the weights and repetition compromise your alignment and exclude movements that will put your spine at risk. Again, site specific. And I will mention, and I'm going to mention it again, that exercises that strengthen the erector spinae, which is the muscle group that you can feel in your spine on both sides of your spine. The rounded fleshy area, I guess is the best way to describe it. They go up and down, it goes up and down your spine. And that strengthening that muscle group has shown fewer instances of spinal compression fractures. Vary your exercise program, rest between sets. Remember to breathe. That's with breath control. I've heard different things about when to exhale. And mostly I've heard to exhale on exertion. But the most important thing is that you breathe with your exercises and don't hold your breath. And give your muscles a day of rest at least to recover. And when you're thinking about weight loss, this came out of Laura, whose name I can never say. Let me see. I think I have it here from G. Gregoria. I'm sorry, Laura. Anyway, she mentioned in the talk that I linked that you don't just lose fat when you're losing weight, but you can lose muscle and you can lose bone. And resistive exercise can help prevent loss of both. So next we have here back extension. And with my Bone Fit program, with Sarah Meeks, with my Margaret Martin course that I took, all of them do some variation of this exercise. It doesn't always look exactly the same, but it looks something like this. I picked this one because it was out of the study from 1984 that determined that flexion was a problem for the vertebrae and caused increased spinal compression fractures. However, they found that the people who were in the back extension group, they had fewer compression fractures even after the study. So therefore, some version of this is part of my exercise routine. So being told I had a bone health issue was daunting to me. Learning about management, having a plan, learning about movement, and scheduling exercise into my routine reduced my fear. The silver lining, better alignment, fitness, and health beyond the scope of bone health, and being able to enjoy the things I love to do. And I wish the same for you if you're on this journey as well. Thank you.
Yeah, thank you so much, Betty. I know I learned a lot from this. It's been a long time since I was really in school looking into the osteoporosis literature and testing. And I think you did such a lovely job kind of highlighting some of the things to look out for if you've just recently been given a medication for bone health and not really given much more than that. So I hope that people download the slides and check out some of the links and the resources that you provided. The other thing is I will link up Betty's Nordic walking poles, whatever her favorite brand was, I'll figure that out and I will put that in the show
I can
notes.
tell you.
Yeah, thank you so much. I appreciate it.
Thank you. Thank you for the opportunity.